Hello. Yes. Uh, is my voice audible?
Yes,
Uh,
sir. Good evening, sir.
Good evening. Good evening. Right then, we'll just start.
Yes, sir.
So today's topic for PG lecture course for MS Orthopedics is the cervical myelopathy, one of the most common cases which you will be facing in your clinics and OPD after you pass your MS exams, right?
Yes, sir.
We'll start with the definition first. Myelopathy, what is myelopathy? And radiculopathy. These are the two most common terms which you hear when it comes to spine. So myelopathy, basically, it is the symptoms and signs which arise due to compression of spinal cord. And radiculopathy, as the name suggests, they are the signs and symptoms which arise due to compression of nerve root. Nerve root. In this case, cervical nerve root. Right? So myelopathy, radiculopathy. What is the etiology of myelopathy? What causes myelopathy? Congenital or narrow canal since birth, spondylosis, that is degenerative cervical spondylosis caused due to ligamentum flavum hypertrophy, disc bulge, facetal hypertrophy, osteophyte compression, or simple PID, prolapse intervertebral disc, trauma, very common in our country, ossified posterior longitudinal ligament, or any compression due to tumor, infection, etc. Right? So, yes, it is more common in men and above 55 years of age, as the degenerative is the most common cause. And 70% of the patients by 70 years will have degenerative changes. Yes, it applies to everyone. It is more common in patients with arthritis, rheumatoid, ankylosing. So, this is the relevant anatomy when it comes to myelopathy cases, cervical myelopathy cases. So, recalling the anatomy classes from first year, just remember posteriorly touch, position, and vibration sensations are located, right? And anteriorly in spinothalamic tracts, pain, temperature sensations are carried out. And one important point to be noted here, you can see here cervical, thoracic, lumbar, and sacral segments, right? They are aligned from inside to outside, starting from the cervical. So this is the cause when the central cord syndrome occurs and cervical or upper limb is affected first. So this is the small relevant anatomy here. Pavlov's ratio, not important very much, but yes, by definition can be asked in theory. So it is ratio is equal to A upon B, where A is the diameter of canal and B is the length of vertebra. So if the ratio is greater than 0.8, it is considered as stenosis or congenitally narrow canal. This is Pavlov's ratio. Yes. So some theoretical things. If asked in your theory, you just have to write down these names. That is, what is the anatomy behind it? Pathoanatomy. Compression we all know, which could be static as well as dynamic. Stretch and strain over the cord, and minor trauma. Physiology behind the myelopathy in cervical spine is ischemia due to compression, inflammation, and apoptosis. So definitely injury or trauma will result in damage to blood spinal cord barrier and apoptosis, right? So this is one such disease in our body whose natural history and prognosis is bad. So this is one disease, that is cervical myelopathy, which will always progress. 75% will have stepwise progressions, 20% will have slow and steady, whereas 5% will have rapid progression. But everyone will have progression. This is not something which will get over or will get better with rest and with time. So I guess this is the most important slide of the whole presentation, which is signs and symptoms of clinical cervical myelopathy. Because this is what you will first notice in your patients. Symptoms of the patients would be most common hand clumsiness, gait imbalance. Clumsiness means he would not be able to write properly. He or she would not be able to tie or untie buttons. Numbness in all four limbs, bowel bladder involvement, neck and arm pain. What are the signs? All the upper motor neuron signs, hyperreflexia, clonus, Babinski sign, motor weakness in later stages. Gait, yes, definitely imbalanced, drunken, spastic gait, wasting of muscles in the hand, which is very common, and all of them contribute to being a myelopathy. And yes, which is one most common and earliest symptom which each and every patient has. That so answer to that would be gait imbalance and clumsiness in hands. This is how myelopathy starts. Very important. Yes, these are the specific signs which you as a clinician should never miss in a myelopathy patient, and which are very specific, right? So Lermit, uh, so from rank wise, I would give first to Hoffman sign. Here you can see in the first figure, this is how Hoffman sign is elicited. Holding from PIP joint of the middle finger, you just stroke the tip of the middle finger, and a movement occurs at distal interphalangeal joint, which causes flexion of all the other fingers. This is Hoffman sign. Finger escape, second figure. Just ask the patient to hold his hand in front of you. This is the normal hand, and this is finger escape sign positive. The last or little finger will go away from the rest due to weakness of the hand muscles. Inverted brachioradialis. Third figure, by stroking the brachioradialis, normally there occurs flexion of elbow, but here flexion of wrist will occur. Babinski sign that you all know, upward and outward fanning of toes. Drunken unsteady gait, Romberg sign would be positive, but it is not very specific. So, in all, Hoffman, finger escape, inverted brachioradialis, Babinski gait, and grip release. Yes, myelopathy patients would not be able to do tightening and untightening of grips more than 10 times in 10 seconds. So, very important to remember this. Yes, you should always be able to differentially uh, diagnose this from multiple sclerosis, vitamin B12 deficiency, syringomyelia, epidural hematoma, arteriovenous malformation. Yes. So most of them would be differentiated from the imaging findings. So what is the difference between radiculopathy and myelopathy? We know the definition. What are the findings? What are the findings which are different in both? So yes, when there occurs only compression of nerve root, that is radiculopathy, reflex for that particular nerve root will be suppressed, that is hyporeflexia, whereas it is always hyperreflexia in myelopathy. Tone would be reduced or normal, whereas tone will always be increased in myelopathy. Sperling sign, very specific, very specific for radiculopathy. Many a times I have discovered my patients, they come inside the room with one of their hand, shoulder fully abducted, and their hand over the head, so which gives relief to them, right? And which is, it is the shock like sensation when you turn your head to one side and then compress it from above. You give the axial force from head downwards, they will feel a current like sensation in their limb, upper limb. And yes, very important aspect from management point of view, conservative treatment is very successful in radiculopathy, whereas conservative treatment is not at all recommended in myelopathy, right? So for example, a patient has C5C6 massive disc bulge, which is compressing both cord and root at that level, right? The disc is massive, so it will compress both root and cord. So as the disc is at C5, between C5 6, so the reflex due to C5, that is biceps, would be suppressed because C5 nerve root is suppressed. Whereas below C5, everything will be hyperreflexia due to myelopathy, that is C6 and C7, right? So this is how you elicit the level in your exam through clinical examination without looking at the MRI. This we have discussed in our first lectures, dermatomyotome of cervical nerve roots, that is C5, 6, 7, 8, T1, C5 biceps, C6 brachioradialis, C7 triceps reflex, right? So just remember this dictum, reflex at the level of compression decreases, whereas everything below that increases. So this will help you to determine the level of the disc bulge in your exams if you get this case, right? So your next question would be, now you have elicited your signs, symptoms, do you know that, and what investigation would you order? Definitely x-rays first. Which x-ray? Cervical spine, AP, lateral, and flexion extension view. What will it show? Osteophyte formation, disc space narrowing, kyphosis, or any instability in flexion extension views, right? MRI is gold standard, always recommended. It, treatment cannot start without MRI. MRI will show diameter, compression, whether it is anterior, posterior, very important, signal changes in the cord in form of edema, ischemia, myelomalacia, or the ossification of the ligaments, ligamentum flavum thickening. All this will be seen in MRI. Now, these two terms, they are not very useful practically. Just you need to know the names. Diffuse tensor imaging in MRI. It will show abnormality well below before the development. We do not regularly do it here in our country. And spectroscopy, it is related to metabolic changes in the cord, and it shows it before it. So this is in nutshell MRI, about signal changes in MRI in cervical spine. It's cervical spinal cord, right? Exactly. So we know that in MRI there is T1 and T2 images, right? There are two types of images we get. So T2 hyperintensity, it suggests edema of spinal cord, and T1, it suggests ischemic death of nervous tissue. So in the early stages of the disease of myelopathy, there always occurs T2. The changes will first occur in T2 images, and then in the last stages, hypointensity will occur in T1. So while assessing both T1 and T2, if you find that in your patient T1 images or spinal cord in T1 plate is normal, then you can say or that the prognosis would be good, and it, while if you operate early, right? So T2 changes are the better predictor or early sign of myelopathy. This is one thing which you should keep in your mind. Looking at this figure, it doesn't show much compression, although there are signal changes in the cord. But again, when the MRI is done in flexion and extension view, in extension you can see compression is very severe. This is the same MRI, right? So you should always suspect when you have the signs, you can elicit the signs and there are symptoms, and it doesn't show in MRI, you should go for flexion extension view. CT scan, yes. When it comes to cervical spine, it has a major role in surgical planning, and it helps in assessing ossification of the ligament, which is very important in planning whether to go for anterior or posterior approach. Again, when it comes to spine, there is always this investigation which you should never miss out in cases needed. That is EMG NCV to rule out peripheral nerve problems, right? And yes, helpful in planning of tandem stenosis cases. Worldwide accepted, these two scorings, they are useful for assessment, grading, and also for post-operative improvement, to gauge the improvement in follow-up every time. That is Nuri grading and MJOA, modified Japanese Orthopedic Association score. Nuri grading from 0 to 5 and MJOA scoring from total would be given from 18, 0 to 18 points would be given. So after the investigation, you have done all the investigation, your diagnosis is confirmed,
Hello.
myelopathy. Hello, hello. Yes. Are you getting it? Is my voice audible again? Hello, hello.
Yes, sir.
Okay, then I will continue. So, you know the sign symptoms. You have seen the MRI, you have seen the X-ray. Now, what will you do? As I have suggested, it is a progressive disease. Progressive. Many times you will face this problem. Your patient will come to you in very, very, very early stage. I myself always have this dilemma that okay, so patient just has some tingling numbness or some hand clumsiness and very, very, very mild gait disturbance. So should I go in and operate early? So in my 10 years of practice, I have understood that yes, now I will always go in and operate early. I'll not ask that patient to just wait and watch and see what happens next, whether it progresses or not progresses. I will just go in, right? So what are the now again the first question which you will get when you advise surgery would be what is the prognosis of the surgery? How good will I get after the surgery, right? So what are the good prognosis factors, right? So first is young age at presentation, duration, very, very, very important, most important, duration. The symptoms, duration of symptoms should, when less than 7 months, 6 months, right? Involvement of pathology, very when the pathology is limited to one or two levels, and presence of unilateral symptoms, not all four limbs. So these are good prognostic factors. So which factors play role in decision making? Duration, most important. Degree of spinal cord dysfunction, the changes in T1 or T2, which we discussed. General health of the patient, always important. Degree of functional deterioration, which would be determined by that those scoring, numeric grading and MJOA score, and radiographic findings. These is something more about radiographic findings. Now you have decided that you will go in and operate. Now again, as a surgeon, there are two approaches for cervical spine surgery in myelopathy: anterior or posterior. How will you go? How will you decide? So these are the factors. Curvature, very important, lordotic, kyphotic or neutral. The curvature of the spine, cervical spine of the patient will determine the approach first. Number of level involves, very important. When the compression is at 4 levels or 5 levels, you will not go in from anterior and do a CDF at all the 5 levels. Not practically feasible. Location of compression should always be in your mind. whether it is compressing the disc is or disc would be anterior, or is it just the ligamentum flavum from the posterior which is compressing the cord, right? Pattern of compression very important, again equally important, soft to hard disc. So this ossification of posterior longitudinal ligament is very common when it comes to cervical spine, and it is a culprit in many cases for compression, and it is technically very demanding to remove ossified part apart from the cord. Surgeon's expertise. Now, at the end of the day, this matters much. You should be expert, you should be skilled in whatever you do. Otherwise, you cannot do that. Characteristics of the patient when it is the short neck, it is very difficult to approach C6 or C7 from anterior. Very difficult. K line and vertical axis. So, what is K line? It is a kind of theoretical aspect, not followed always. But yes, K line means when the line drawn from C2 to C7, midline of C2 canal and midline of C7 canal, the perpendicular which is drawn, and this K line concept of K line is used only in OPL cases, no other cases. First thing. Secondly, when the OPLL it is anterior to the line or it doesn't touches the line drawn, it is positive. So the compression, the it means there is lordosis is well maintained, preserved. You can go in from posterior. If K line is negative, that is OPLL crosses the line. And when does it cross? It crosses only when there is kyphosis in cervical spine. So you need to address it anteriorly. This is not a short thing. It is not a very good dictum. There are other factors which you should consider apart from K line first, right? So yes, this should always be kept in mind. In case of lordosis, you can very well go posteriorly. In case of kyphosis, you should not go for only posterior surgery. You should try and get the kyphosis or kyphosis of the cervical spine corrected by fixing it posteriorly or doing ACDFA
Hello.
anteriorly.
Hello.
I
Sorry. Just waiting for a second.
don't know.
So again, very important slide. So all this is easy up till now. You will elicit the signs. You will order MRI. And now comes the brainstorming part. What will you do as a surgeon? Whether you will do anterior surgery, posterior surgery, or you will do both in same case. So how will you decide? When will you go anterior and do anterior surgery through cervical discectomy and fusion? So common points for anterior surgery: 1 or 2 level disease, maybe 3 level. When the disease is anterior, that is the disc bulge. When the kyphosis is present, you will always try to go anteriorly so that you can get proper lordosis, normal lordosis alignment in the spine. Presence of neck pain should be considered while doing anterior surgery, right? And when we'll go posterior, more than 2 diseases, three or 4 or 5, 6 level diseases, it is always easy, very easy to just go posterior. Lordosis is well maintained, so you can do posterior surgery. When the anterior approaches are difficult, in cases of short neck, obesity, levels above C3 or below C7, they are very easily approached posteriorly. So what are the advantages of anterior approaches? So yes, pathology can be directly addressed. Anterior pathologies, blood loss is very less, infection chances are near to nil, and alignment we can get correction of the disturbed alignment. Advantages of posterior approach: decompression is under direct vision. You can see the cord, whole cord. Yes, anterior vital structures which are carotid artery, esophagus, trachea, they are not coming in your approach posteriorly. And lesser surgical time with advanced technologies available like ultrasonic bone scalpel, it becomes very fast to do a posterior surgery. So yes, damage to anterior structures, which we just discussed, can occur in anterior surgery. Duration is more. Dysphagia or other complications can occur. Blood loss is more in posterior as compared to anterior, not much high. More chances of infection, can cause kyphotic deformity without fix in cases where we do not fix, right? And when do you do both surgeries? Anterior plus posterior. When do you do it? You do it when there is a revision surgery. You have already posterior laminectomy has been performed. So in such cases, and rigid kyphotic deformity cases. In rigid deformity cases. So these are, in nutshell, indications and advantages, disadvantages of both the approaches. So all these you will get in your books, but one always needs to form their own protocols. What you will do when patient comes to you, that you have to decide, right? So what is my protocol? When the patient of cervical myelopathy comes to me, I always get a lateral AP X-ray and flexion extension X-ray before operating any cervical spine, right? Where I see kyphosis, listhesis, osteophyte, then I order MRI. Never operate any spine below a whole before a whole spine MRI, right? May it be of cervical spine case, may it be your lumbar spine case. Always get an whole MRI, whole spine MRI done. Always. Never write LS spine in any of your cases. Never. Although patient has complaint of only low backache, your pen should always write LS spine with whole spine screening in the paper to order MRI throughout your practice. Make this habit from the first day of your practice. Pathology, I will determine the pathology, whether it is anterior, posterior, number of levels. I will see chord changes. I will draw K line and CT scan. I will order a CT scan whether it is single level 2. I just want to know whether it is OPLL or not in case of CT scan. So after this, what will I do? If it is one level or two level and OPL is absent, definitely I'll go for anterior surgery. Three or more levels are involved. OPL is present, I will go for posterior surgery. Instability, which I will determine from flexion extension view. If the instability is present and if it is corrected on extension view, in flexion we can see the instability, and if it gets corrected on extension view, I'll just go posterior. But yes, I will also fix the cervical spine in corrected position with lateral mass screws along with laminectomy. But if the deformity, if instability is non-correctable, if it is rigid on flexion extension view, yes, these are the cases when I will go anteriorly first and then posteriorly also. So sometimes you get one or two level anterior compression, but you have OPLL, right? Plus lordosis is well maintained. You can go away with laminectomy, and you can always tell the patient that if it doesn't improve, we will go in for anterior surgery. So this is something which will help you, right? That is anterior, posterior. What number of levels of compression, alignment of the spine, and yes, it is correctable on flexion extension view. Laminoplasty, not really important for you to know. It is obsolete. This procedure is obsolete. It is not done nowadays, right? So this is what we have already discussed. Laminectomy, which is just the decompression of cervical spine. When do we do? When the spine lordosis in cervical spine is maintained, patient doesn't have neck pain, right? We do only laminectomy from the posterior. So less blood loss, less operative time. Yes, it should not be done when there is kyphosis in cervical spine. Only laminectomy should never be done. Second option, laminectomy plus screw fixation, lateral mass fixation. So when there is instability, you fix it. Very simple concept, right? But they're all there. With the fixation, there comes the disadvantages of implant failure, misplaced screw. It requires a great amount of experience, high skill while fixing cervical spine. Lumbar spine or dorsal spine can be forgiving. but you do not get a second chance at all in cervical spine. There is only one chance if you want to put a screw in that vertebra on that side. You will not get a second chance at all. Never. Right? So take home message of today. Pavlov's ratio greater than 0.8 means congenital neurosis. Spatial signs which you should never miss. Finger escape, Hoffman, grief release, and hyperreflexia. Remember this dictum, reflex at the level of compression will decrease, and below that all the reflex will be exaggerated. Signal changes in MRI, in cervical spinal cord, in T2. If only T2 is affected, it would be reversible. It can be reversible if you operate early. But when the cord has started showing changes in T1 also, it is irreversible. The prognosis would not be very good. You can very well tell your patient about it beforehand, before going in the surgery, and warn them. Get a flexion extension MRI when there is no radiological clinical correlation. 1 or 2 level neck pain or kyphosis, I go for ACDF. Greater than 3 levels and lordosis is maintained, I do only laminectomy without fixation. Greater than 3 levels, if there is kyphosis, yes, I fix it. So this is the take home message of today. I hope you have understood. These are the most important points about the myelopathy and take home things. This, believe me, these cases are very common when it comes to practice. Very common, as it is degenerative, right? So, two of you, any questions regarding myelopathy, or you want to discuss anything else regarding
Sorry,
myelopathy?
sorry, management. There is a point of neck pain. If there is a neck pain, we will go for anterior approach. So if
Yes,
it is more than 2 levels and there is lordotic is present and there is a neck pain, then after we will also go for anterior approach. Or
more than 2 level and neck
yes, sir.
pain, right?
And lordotic.
Okay. So, if there are more than 2 levels and lordosis is maintained, right? And
Yes, sir.
neck pain. Now, neck pain, right? This term is very vague nowadays. 80%, according to the statistics, 80% people of the world, 80% people
Yes,
living in this world, not only in India, in this world, will have neck pain in once in
yes,
their lifetime, right?
yes.
So you have to determine whether that neck pain is significant or not, or very relevant or very significant or not. So should it be considered while doing while planning your approach? If it is very significant, if the neck pain is hampering the patient's functional ability, then also you can go in just posterior and fix it. Do
Okay.
not leave it just by doing it laminectomy. The concept of the treating neck pain is that when you fix the spine, neck pain will go. When you fuse the spine. So
Yes.
fusion can be done anteriorly also, posteriorly also with screw, right? So
Hmm.
in that case, when more than 2 level lordosis is maintained and patient has significant neck pain, just go in posterior, do the laminectomy, fix it with lateral mass and fuse it.
Okay.
I will do that,
Yes.
right?
And sir, in radiculopathy and myelopathy, there is a one Spurling sign. Can you tell it again?
Yes.
Hmm.
Sperling cell is specific for radiculopathy only, not in
Yes, sir.
myelopathy, right? If there is
Yes.
myelopathy, Sperling sign will not be positive. It is specific for radiculopathy. Radiculopathy means compression of nerve root. What is Sperling sign? When the patient comes to you, just make him sit in front of you in the chair.
Hmm.
Just abduct the shoulder. Hold your patient's hand from the wrist.
Yes.
Abduct your abduct his hand lightly. Abduct his shoulder lightly. Hold it from the wrist. Ask him or her to look to the other side, opposite side. Just asking you to turn around to the right, right?
Yes.
After that, or how is it done? You just leave your hand, you stand up, stand behind the patient, just apply axial force downward from above his forehead, his or her forehead, downward. So he will feel current like sensation going down through the arm from neck. So it
Hmm.
is just the compression of nerve root when axial force is applied,
Yes.
which is same like when we give the nerve root block in the lumbar spine. When the needle touches the nerve root, a
Now,
current like
yes.
sensation occurs in the leg. So similarly, it is Sperling sign,
Yes. Thank you, sir.
right?
Yes.
Uh, Good then. Where are you two from? Which college or?
Sir, I'm from LG Hospital, Narendra Modi
Okay,
Medical College.
good, good, great. No problem then. If
Yes.
there is nothing more to discuss, we'll just end here.
Thank you, sir.
Great, great, good. Thank you.